before we get started today, I just wanted to provide a brief overview of the CTSC for those who are not familiar that are on the call today. So the goal of the Clinical and Translational Science Collaborative, or the CTSC, is to improve the health and health equity of people who live in Northern Ohio by providing resources and services to both our hospital and community partners, clinical and translational researchers and scientists, as well as community members. So the CTSC is currently accomplishing this by focusing on these 5 key areas that you can see on this slide. So this is resources and services, community engagement, workforce development, clinical and translational funding opportunities, and health informatics. And then the next slide. So I just wanted to take a brief moment to introduce our content expert for today. So Alicia Thomas is the Director of Bionutrition Research here at Case Western Reserve University, and she also leads the Bionutrition Dietary Call Center on the DOMS Clinical Research Unit at University Hospitals. Alicia has extensive experience in clinical bionutrition-related research and dietary methodologies that include nutrient intake and analysis using nutrition data systems for research. So today she'll be giving us a brief overview of the field of bionutrition, and so I will turn it over to you, Alicia.
Great, thank you so much. Thanks for having me. This is our agenda for today, but before I get started with that, I wanted to say, thanks to the cheerleaders for allowing me to talk about, bionutrition. I love talking too, but also we're really trying to push our marketing for the usage of bionutrition and just to get the awareness out there. So I do appreciate those cheerleaders who said, hey, ask Bionutrition to do this. So that's number one. But number two is a little bit more selfish, and that is that my husband is one of 12. And so we have a lot of in-laws. There are 40-some nieces and nephews. I grew up in a family with all sisters. We have 4 grown daughters and 3 son-in-laws and almost 4 grandchildren now. So I will tell you that the ability to talk for 30 minutes without getting interrupted is really it's kind of nice. So anyway, thank you. Selfishly, that's a little bit about me and all that. So here's our agenda. I want to talk about what the heck is bionutrition. And we'll go through the bionutrition, the history of it nationally, locally. We'll talk about our services here on the unit and just some of our challenges and things that are up in our future, things that we're looking at doing. While I talk, I know that we're going to have a lot of research people on here, whether you are or not, whether you're conducting your own research or not. I want you to think about what kind of services, nutrition related, would you like to have, what kind of equipment, if money's not a barrier, what kind of studies would interest you, and just think about this. And then we're going to ask it again towards the end here, and we will and have you put it in the chat and things like that. Okay, so what is bionutrition? So when we talk about it, our division didn't used to be called Bionutrition, it is now, and this refers to all of those bionutrition divisions or cores that are within the CTSC programs across the country. I think of bionutrition like a Russian doll, and that is that you can't really, we're within an institution, within a hospital, within a unit, within a center, within. So we're here, we're small, but we're part of this whole bigger organization. And so if you think of it that way, that's kind of what bionutrition, where we land. And bionutrition has been dedicated to supporting nutrition-related research. These cores, these divisions across the country frequently have the same kind of resources. So they may have expertise in energy expenditure and exercise testing. That might be the portfolio of the particular unit. They may have metabolic research kitchens. They may have software that allows them to do dietary intake assessments. They may do body composition testing, whether that be skin fold or underwater weighing or DEXA or whatever. They can provide education and training, not only to our participants and to the study participants and study teams, but also to researchers in training. For instance, dietetic interns come to mind, or fellows or junior investigators who just want to learn a little bit more. So we can provide that kind of education and training. And then also in bold here, I have research support, because it is something that's not always tangible. Like, you can look at everybody's website and see that these services, we have these tools, we have these, I call them toys, and all these things that you can play with in our centers that are nutrition related. But research support definitely means, doing a consultation at any point in the research, but also with help with study design and protocol implementation and how to analyze and interpret this nutrition data so that it makes sense to you. So this is something that I bold it only because it's not any more important than all these other things, but it's something that is kind of in the dark. Here's a little bit of history of bionutrition. And again, like I said, we didn't used to be called bionutrition. We used to be just called nutritionists, the nutrition units, and they've changed that over the years to make it more, comprehensive of what we actually do. It's not just diets and assessment. There's other things involved, body composition and things like that. So here is, and this is not necessarily relevant to today's environment, but it does give you a picture of how bionutrition kind of came here. And so 1959, we have NIH has established these, what they're called GCRC or PCRC programs. That stands for General Clinical Research or Perinatal Clinical Research Programs. Now, I'm going to go through this timeline, and I don't want anybody to fact check me because I could have dates, not quite right. But this is to my knowledge, and I've been around for a while, so I think it's mostly right. But anyway, these GCRC programs were patient-focused, bench to bedside type of studies. They had the funding that provided the infrastructure, the staffing, the equipment, the labs that are drawn, all of that. And this was available to NIH investigators at no charge. And so for a long time, that was the purpose of these GCRCs, PCRCs, was to allow these investigators who had funding, but to give them, to help them along with their research. And a lot of these centers also staffed a dietitian in these GCRCs/PCRCs. And maybe they weren't full-time, maybe they were part-time, but they had a piece of a nutritionist in all of these centers for the most part. And these dietitians, they had this expertise, and you think about this is in the 50s and 60s, 70s, in controlled feeding studies, some body composition assessment skills, a lot of nutrition assessment. And I was telling Mackenzie earlier that while I was putting these slides together last night, I came across a journal that I knew I had. But this is our Clinical Research Unit metrics book, and it's from it starts in 1962. And it has every diet that the Bionutrition Division calculated and served and what kind of studies they were. And it's a hand ledger, so it just kind of cracks me up. So I can't throw it away because it's just a part of nostalgia, but it dates to October 1962. And the diets of the time that we were calculating and serving were calcium balance and sodium and potassium balance, and even starvation diets for all kinds of stuff. So it's just kind of crazy. In 1992, we had this organization called the National Association of Research Nutritionists. This was formed, and it was these nutrition people who worked in these GCRC programs. And what we did is we formed this kind of membership and this association that allowed us to standardize a lot of our expertise across the country and across all centers. And we would meet, these GCRC programs would meet annually, and they would have, the program directors were there, the nurses were there that worked in these units, the lab, the computer, the bioinformatics people. And we would meet every year, and the nutritionists would have their own programming. And we would talk about landmark studies that were going on in other centers and how best to do different things and best practice in a clinical research environment. Now, mind you, we were all dietitians, we all have degrees, we all have registration, you know, we're all licensed and all that, but we all didn't go to nutrition school, I'll say that kind of simply, learning these things. This is something that it's not like necessarily taught back in my day. And so you had to learn these from the experts out in the field. So these were very, very important to have this association and to be able to have this expertise grown in this very, very small kind of group, this community group. So the NARN, they met quarterly, regionally, they would have an annual meeting, we pay dues, we have webinars, and to this day, even though there's no more GCRC anywhere, we still meet and we still pay dues and we have bylaws and we still have resources. And so it's something that we all, we can't just turn to our, to people that we work with and ask for these things. We have to, you know, pull from these experts across the country. So that's a side note on bionutrition. In 2006, NIH starts phasing out these GCRCs. So there's, I don't know if this is right, but 75 plus, I think it's about that. And then they transition to this institution-wide training, education, collaboration that we all now know as CTSA. And so by 2014, there is no more funding or infrastructure for staff that's at the same level. And now this is when we start introducing fee-for-service models in our units, especially with bionutrition. And by 2022, 38 of our CTSA hubs across the country have a dietitian with bionutrition units in it. So this just kind of gives you the scope of, we've been around a while kind of thing. Okay, this is showing you just where these bionutrition divisions are across the US. This is from a colleague in California who did this for us. And here I was talking about the landmark projects that we would talk about at some of our meetings, those annual meetings that we would meet. And so here's just a list of some of the things that those bionutrition units and personnel were working with, and the investigators they were working with on these different kinds of studies. And you know, clearly these are projects that impacted policy and practice and things like that. Now, this is the history of DCRU bionutrition, which is where I kind of come in. And this dates back to our clinical research unit here. It was established a long time ago. I think it was funded 60 plus years ago. Again, don't fact check me too much on the dates. I have very limited historic information while I was getting this together. But I believe it was in the late 50s where our clinical research unit was established in Lakeside 55, because I have a journal from another journal that is a guest book. And it is, we had, you know, patients would come into the center and they would sign their name in a guest book and where they're from. So I know the researchers out there are like cringing, but we have it. And so those date back to 1958. And we were located on Lakeside 55, the unit was. And in this unit, we had a tremendously large research kitchen, kind of bigger than most restaurant kitchens, if I remember right. The institutional kitchen, a couple stoves with a lot of burners, traditional tray line. It had, if you're in food service and if there are any nutrition people on here, you know, it had a great big kitchen, and then it has the fishbowl offices that the dietary manager can peek out and see what's going on. So there were 2 of those, and it was big, it was massive. And it wasn't just UH doing feeding studies here. So it's a heavy focus. Their portfolio was on diet studies, nutrient controlled, metabolic feeding studies, just kind of what you would expect in the 50s and 60s. But also, Metro Health Medical Center was asking university hospitals for food for feeding studies. And so I know this because it was me, I was at Metro Health Medical Center. I started there in their research unit in 1989. But I had investigators who wanted, this particular investigator, Dr. Hudgel, wanted to do tryptophan depleting studies. And I had no kitchen. And so I had to call our dear friends here at UH and say, I need food. And so Metro Health Medical Center in the mid-90s was asking UH to be part of, to assist in food procurement for their metabolic studies. In the 1990s, and again, 1995, 1998, right around there, we moved to Rainbow 7. And here, our portfolio changes a little bit more. We do have a kitchen. It's not as big as a lakeside kitchen. It is about half the size, maybe a third of the size. And also now we have a family kitchen. So we're located in Rainbow. So Rainbow is more family focused. And so it makes sense to have this other opportunity. So it cut our footprint of a kitchen in half. We're doing a lot of anthropometric studies. So we have a skin fold assessment. We have calculating, body fat from that. We are doing nutrient controlled diet studies at UH still, even with a smaller kitchen. But now we have new players. We have Cleveland Clinic now, who also has a clinical research unit, but no metabolic kitchen. And so we have the NASA study, and this is an inpatient 12-week feeding study. We have Dr. Kerwin had I think it was a 12-week outpatient feeding study. So we have researchers who are utilizing university hospitals again and their metabolic kitchen and their expertise on serving their feeding studies at their institutions. And we're also doing a lot of dietary intake assessment, which seems to be kind of a common thing in a lot of centers across the country. And we were using, I don't remember off the top of my head, Nutritionist Pro maybe, and I don't want to badmouth any software that's out there, but it's kind of like what's on your Fitbit. So it's like, it's not, it gives you calories, gives you protein, but it's not going to give you a lot of nutrients. So we were working with an investigator, Dr. Susan Redline at the time of this, around 2008, I think. And she came into my office and we were collecting all kinds of skin fold measurements on her patients, and we were collecting all kinds of dietary records. And she said, how can you call, and I'm not kidding, how can you be a bionutrition division and not have better software? And I said, I agree with you 100%, but it's not my fault because I don't have any money. And she says, I'm going to find you money. And she found a way to purchase our first version of NDSR, which I'll talk about in a minute. But this is sexy software. And so this is the software that researchers across the country use. This is gold standard for dietary recall assessment, and if you ask any bionutritionist across the country. So Dr. Susan Redline, I call her our first cheerleader of bionutrition, was the one who said, she kind of handed me this gift. So it was just this beautiful thing that we had, this software. We're at Rainbow for maybe 20 years, and again, give or take a few years. We moved to Lakeside in 2018. And here our portfolio in terms of like what kind of studies people are doing that are nutrition related are a little bit different. Now we have a DEXA. So the DEXA is new. We purchased it actually when we were on Rainbow, and we had another cheerleader enter the picture. That's Dr. Grace McComsey. And she came into the unit and in 2016 said, how can you call yourself a bionutrition unit and you don't have any body composition equipment? So it's the same kind of thing. I agree with you about how many money. And so she says, I'm going to find you money. Somehow somebody found money. And so we purchased a DEXA. So thanks to Dr. McComsey. So just a side note, I had come from 18 years of being at Metro Health Medical Center with loads of body composition equipment. So I had indirect calorimetry, bod pod, P pod, DEXA, underwater weighing. So I came from having a lot to nothing, and so the fact that she offered this up was a big deal. So we love our DEXA. When we moved to Lakeside, we didn't have a kitchen, so we built one, but it's even a smaller metabolic kitchen, but it is new, and I'll show you a picture of that in a minute. So we still have that. And then we have heavy usage of NDSR. We still do. So we've been collecting dietary recalls since the beginning of time, but with this super sexy software, for about almost 20 years of dietary recalls using this software. This is asterisk because I'm going to talk about it again in a minute. Okay, this is a very, very busy slide. I'm sorry, but there are a lot of pictures for you to look at while I talk. Okay, in no particular order, these are our DCRU Bionutrition services that we have. It's not in any special order, it's just kind of slammed all together. We can do nutrition education, lifestyle counseling, intervention work, anthropometric assessment, and we can do that. We don't get that requested as much anymore. And so the things that are listed here, skinfold assessment and master trainer for study teams and expertise in neonatal and body composition assessment, that it's weird. It's weird that we have that skill set, but I have this little quote. Did anybody see Taken, the movie? Where Liam Neeson says, I have a very particular set of skills. I always feel like that's when people say, how come this dietitian knows so much about this neonatal body composition and assessment and be a master trainer in skinfolds? It's because I did this for a long time at Metro Health Medical Center. So over the course of 18 years of my career, I just learned this, became a very specialized skill set. So anyway, so it's there for the taking if anybody wants that. But we also do a lot of dietary recall assessment and analysis using this super sexy software, NDSR. So it stands for Nutrition Data System for Research. It was developed by the School of Public Health from the University of Minnesota. It is a national gold standard used, like I said, across the country. It is a gold mine. And so when I say a gold mine, I just mean that every single center across the country using it has been trained the same way, because we have this National Association of Research Nutritionists who demand that everybody gets trained the same way, or it's the gold standard. We always searching for best practice, so we all do the exact same things on NDSR. And all the exports, no matter where you are, they all look alike. And so if you're doing research here and you're using NDSR and you have a colleague that's out west and they're using NDSR, it's really easy to manage from a logistics standpoint of merging or comparing the data, because it all kind of looks the same when it comes out. Our call center is, it's really a room, but we call it our call center because the people who work in that room work pretty much round the clock on, I'll say round the clock, but we do let them go home. They work in any time zone. So we're used to doing studies that are all different time zones. We have patients who don't necessarily want to be called and talk about their diet between the hours of 8 and 4:30. So for instance, we had somebody here last night late because patients needed a phone call, after work hours. And what's also nice about NDSR is that the exports come out and we can feed those in and run things like healthy eating index. So that's something that we have several investigators, most of them are interested in, that score that looks at kind of your diet quality. And we can use our NDSR data and kind of get you that number as well. We have our DEXA, and I know it's a cartoon picture of our DEXA up there, but that's what we have. But anyway, this is a Hologic Horizon A. I believe it's maybe the only one in the system, and when I say UH main campus, I don't think we have another one here that's just like that. The the DEXA was developed for bone mineral density. So this is what it's known for. Over the course of decades of research teams and bionutrition centers across the country using it for body composition assessment. At the time, this is the backstory on this, Hologic had no intention of allowing us to use that machine for body composition. They only wanted it for bone mineral, and we all kind of complained enough, I think, and then they wrote software so that now it's pretty much only used for body composition assessment here on our unit. But of course it can do bone mineral density for those bone mineral density studies, but it also can do body composition, body fat, visceral adipose tissue. It can look at trabecular bone scores to see the quality of the bone that's there. It has a large capacity. It is, we do have pediatric software that I'm not sure how often we've really used it, but it's there, so we could do many different populations. And what's nice about this piece of equipment is we have just a couple people who are certified at running it, so their skill level is pretty high. And so it's good because the data is good, the scans are very consistent, but also scheduling is really easy. So this is a separate standalone piece of equipment in our unit. And so scheduling it, you can pretty much have it when you want it, kind of thing. We have our new metabolic kitchen. If you look at the bottom, like 2 right pictures, it's kind of an empty, you think, oh, that must be like the pantry we're looking at. No, that's the whole kitchen. So it is small and mighty, like the Russian doll, remember, but we don't have a portfolio that's doing, you know, huge feeding studies anymore. It's not feasible for investigators. It's a lot of money. The studies that we do are very small. So they need 1 patient fed for 2 weeks, very specific, you know, so we can do that here, or we need something weighed out, particularly for, you know, an industry study, we can do that here. So that's kind of what our kitchen is used for. It is licensed. We all have the certifications to be in there and work. And down there in the middle picture are 2 people working on packing a cooler. So this is just a picture of us packing a cooler to be shipped out for an outpatient feeding study. Did I cover everything here? I think I did. So other services that we have. So I'm happy to do a consultation anytime. I had an investigator, actually our medical director asked me, you know, can you do that? I'm like, I'll do it anytime. I'll give anybody my phone number. Anytime you have an idea and you want to talk about something, hit me up. So, but I want to say, and this might sound a little crass, but think about funeral pre-planning. So, and I say that because if you do a funeral pre-plan, you kind of, it's a better bargain financially, but also it's better for everyone. It's less stress. It's just better. It's a peace of mind. It's all that. So I think about, you know, when you have an idea, come to me early. This is going to sound also crass. It is a kiss of death sometimes when you come to me with a protocol already built, and that hardly ever happens, but sometimes it does, and we can't work around it because the protocol dictates what has to be done. So we just want to make it feasible for anybody doing nutrition research. So this is the gold standard. Come to me first. Let's chat. Of course, you can do what you want. Of course, we'll do what you want, but it also might save you time and money in the end. Okay. Help you with protocol development, study design, and that happens anytime you want. It's the interpretation of the diet data that I find right now in the past 2 weeks has been really important. So at any time, you're going to, you know, if you're an investigator and you're getting all these data exports and you're trying to make rhyme or reason out of them, it's a lot of data, and it's just a lot. And if you don't understand how NDSR works and what all the categories are and what these little codes are, it's hard. And especially if you don't have an NDSR expert in your core or in your research team. So at any time you're looking at your data and you just want to know what the heck you're looking at, call me. I'm happy to help you with all that. So this also helps when you're preparing your manuscript. I don't know how you did this. Will you help me? We'll feed you all that information so that your manuscript makes sense. Okay, this is just some of our teams here, what we're working on. We have dietary intervention studies going on with prostate cancer. We have people, and that's somebody that's using our dietary or our metabolic kitchen. We have investigators who use dietary recalls to address some food insecurity issues with pregnancy and high-risk populations. Cleveland Clinic is doing studies with amino acid supplementation and liver disease. We have somebody looking at sweeteners. Both of those amino acid and sweetener studies are people using our metabolic kitchen. We've done body composition changes in all kinds of populations. We do dietary assessments and diet quality for all kinds of groups. So this is just, if I left somebody out who's on the call, I didn't mean to. This is just, these are things that are hitting us maybe right now or over the past 6 months or so. So what are our challenges? Well, I will tell you that I think, I didn't really ask, I just think this is true, but for me, it's engaging participants. So we have this increase in virtual visits, and it's not because of COVID necessarily, maybe a little bit, but we were doing virtual visits before COVID out of patient ease and out of just scheduling. It's just more convenient. We can't have a face-to-face conversation with somebody who lives in San Francisco. So, you know, the call center kind of is used to doing these virtual visits. But it's really hard to build a relationship with somebody that you never really physically meet or see or look in their eyes or smile at. And so I feel this is a challenge. It's kind of hard to connect with patients. So it's, you might, if you're a patient on a particular study, you know, and you have to get here, either, you know, you'll get here, you're going to sit down, talk to nutrition, you're going to have these one-on-ones, you're already here for maybe blood draws and all those things, it makes it easy. But if you don't have to pick up the phone when we call because you forgot or it's not really considered like an appointment, it's just hard to get a hold of some patients. And so it becomes like, it's just hard to connect. So if we can form a connection or engage patients earlier on in their research path of the study they're on, then I think it would help with retention. And so that's what I was kind of getting at, engaging the patients and keeping on top of them and making sure that they're not, you know, blowing us off basically when we call. I think this is the hardest challenge we have. And then the next challenge would be recruiting new studies and new investigators. And so this is, right now, I think this is the 4th or 5th time I've done a talk in the past 4 or 5 months that hopefully will stimulate somebody out there to do something, maybe, but at least to get the awareness out. So know that we exist, know where we're from. We're not some new thing. We've been around for a long time. But so these are kind of our 2 challenges we have right now. Obviously, we'd like to be so busy that we have to hire new people. What are our potential collaborations? So I kind of broke this down into, you know, local, regional, national. So clearly, locally, we have lots of institutions here. We have Northeast Ohio filled with research institutions, all of our affiliates with CTSC. We have community partners that are currently working with a lot of our researchers on agendas that are you know, community health initiatives. We also have current projects that are going on in all the institutions that might benefit from a secondary nutrition aim onto already one of their existing studies. And so this is something that, you know, we talked about this earlier this week in a meeting that, oh, we could tap existing investigators and just see if there's anything that they would want to add on, you know, if they could. And so these are some local potential collaborations. Obviously, regionally, we have 3 CTSC hubs in Ohio. I've worked with all of them, with both of them, Midwest and Eastern. If you looked at that map at the very beginning that I showed you, I mean, it's heavily, bionutrition units are heavily, you know, concentrated in those areas. On a national level, remember that this division of bionutrition across the country use similar tools. We're trained similar. Where, you know, best practices, we've all been around for a long time. And we all have, you know, we may or may not have a DEXA, but, or we may not have a kitchen, but we pretty much all have the same kind of tools. But we also, a lot of us use NDSR. So that is something that it is, I'll talk about that in a second. I don't want to get too far ahead. Oh, here it is. So on our horizon, here we are, if we could wish. What we want to do is we want to provide a better in-depth training for new study teams. So like I said, I've met with several study teams over the past couple weeks, and their NDSR data is a lot. And so what we've decided, actually, Dr. Borowski and I decided this week that we would offer some kind of a more in-depth NDSR overview or workshop for our data coordinators or study teams or, you know, the PI or whoever from study teams who are using NDSR so that they can understand it better, so that they can, you know, they can write and interpret the data easier. We still want them to use us, of course, but this would be a way for them to kind of learn more about it in a more formal setting. You can go to NCC, which is in Minnesota, and I think a couple times a year they offer a course. You sit there for 4 days, it costs you a couple $1,000, and you learn all there is to know about NDSR, and then you come home. If you have NDSR in your institution, then you could use it. But if you're not using it all the time, again, it would be very difficult to keep up with that skill and understand what that means unless you're using NDSR all the time. We're looking at the feasibility of developing a bionutrition-focused research apprenticeship. Don't ask me how it's going to be funded. I'll get to that maybe next year. But just looking at who's interested, is this worthwhile, and what would they do? And my initial thought is that, you know, we have, and we talked about this yesterday in a meeting, is that we're trying to get, you know, people interested in working in research, right? So if we could have some kind of an apprenticeship that would bring somebody in, maybe in their gap year, or somebody that graduated and they don't know what they want to do yet with their life, and so this would be for them. And they would learn everything there is to know about NDSR. They would get fully trained on NDSR. They would get fully trained on DEXA. They would work with a nutrition-focused research team for so many hours a week as like a pro bono coordinator. They would learn coordinator skills. And so that's kind of the thought that I have. And I would love for anybody to kind of weigh in at the end of this and let me know that they think this is a good idea, because I think it's a great idea. But this is something that we're just we just started talking about this with some groups here at UH. And then the swan song. I wish I had a picture of a swan. So I won't be here forever. And one of my wishes for the past, 20 years, since, well, I guess not quite 20 years, 17 years that we've had NDSR, I'll say, is that it would be great if this NDSR data wasn't just like on a server somewhere or, in all these different pockets. It would be good if you could look at, you have these 3 investigators who have looked at, just say, I don't know, cardiovascular disease in these 3 populations, but all their projects are different, and it's all housed in this weird kind of way. So it would be really great if all this could be housed like maybe in a REDCap. And so, of course, it wouldn't have any PHI in it, but it would be like a disease-specific nutrition database. And I've talked about it, and it's not something that a bionutritionist can do all on their own. This definitely needs like buy-in from bioinformatics, which I have already talked to that person. And so I think what we would do ideally is, and we have the REDCap set up now to kind of start pulling things in into REDCap from NDSR now to see what it looks like just with 1 or 2 studies here, and then see how that looks and what would it look like. Move to Ohio, all the people that use NDSR in Ohio, merge it, and then nationally. So it has this potential to be a bigger database that would be maybe used for researchers that need some background data, maybe it's for students, whatever. I don't know the mechanism of who's going to run it, but I do have an idea. Okay, at the beginning, I asked you about this, so I hope that you can think, and is there anything that you would want from nutrition if you're a researcher or you're a clinician or you would like to see studies done on, and money's not an issue because we'll worry about money later, but this is the time that you would probably put this in the chat and just let us know, and I'd be appreciative of that. And I think that's all I have.
All right, Alicia, I wanted to say thank you actually for presenting. So keeping with Science Cafe, it's supposed to be, a discussion now. And I think I see some big names in nutrition on, which is always good to see. Maybe they can give feedback on a couple things, right? One would be for CTSC purpose. Definitely with RFK Jr., nutrition is going to be an area where we expect a lot of RFAs, a lot of attention. And honestly, that's the part I like, actually, is that they care about looking at food and not just medication. So what can the CTSC do to try to drum up interest in bionutrition research and also help you prepare for the next RFAs, for the next big applications and projects? So that's the first thing I would like people to comment on if they want to. And the second thing I think you alluded to, anything that you think we're not doing, if you're a bionutrition researcher, we're not doing within what Alicia and her group are doing, that may help, if you could let us know. The CTSC is always looking for areas to grow. And we did a theme pilot on integrative medicine, we got good projects, 4 were funded, 50K each, but none of them, I believe, were on nutrition. So we wanted, nutrition included, and we had no application. So we may end up trying that with only bionutrition, but I want to see like what, people who are listening, who do that type of research, maybe give us some input into how important you think that the CTSC would put resources, what do you need to get ready for the next big projects in nutrition. Oh, I see.
Well,
Elaine.
Yeah, I was gonna say, I'll jump in. I mean, Alicia and I talk so much about all of this. I mean, I think if there are things that affect us. Now, we use the NDSR in our community samples. And I can just vouch that Alicia's team is amazing. I mean, to be able to reach out to our community folks, based folks and get these NDSRs is no easy task. You're basically getting them on the phone to talk about what they've eaten for the last 24 hours. And a lot of these folks are real, this is a lot of stress and a lot of people are pregnant and there's, to do this is a challenge. So that part is expected. I think on the side from ours is that it is still a very expensive process for us. Right. I mean, and it has to be because we're basically paying for, each one of those calls to be made. Right. I'm sure it's still being covered a lot more by the core, but the expense is still pretty high for community-based projects, I would say. And the second one is the one that I think you and I have talked about, Alicia, is just this helping us fill this gap between, like, I don't need to know necessarily how they're collecting it in terms of the phone call, right? Or even how you're downloading it. Right, that part is a whole other issue. Like, how do we get it into REDCap easily? But it's that space of, like, I remember the first time I asked you, well, can you give me a code book so I know what and you just laughed. And now I know why, because there's thousands and thousands of variables that come out of the NDSR, right? And so I think having something that helps bridge that understanding would be huge. And I think the more we understand it, the more likely folks would use it too. The only other thing I could think of with regard to an NDSR that I think we might use, and I'm thinking, Melissa, I think you're on the call too, like around meals, is to use I'm assuming the NDSR can also be used to look at, like, for example, in the medically tailored groceries that are provided by the food bank, could the NDSR be used to document what actually is in that box and then calculate? I mean, that would be right. We can't guarantee necessarily, and there's not always a connection between the food that's provided and the dietary recall, right? So one way in which that could be connected is a way in which to evaluate at least what food is given, which we don't do currently, because it would be a whole other set of expenses. But I mean, that's another unique space for that. But
well, for sure we can do that. I'm going to jump in. 100% we can do that. Hit me up.
Yeah. Cost. Melissa, see your, yeah.
Yeah, Elaine, I mean, Alicia knows actually, I've always resisted increasing costs. When I was, the UHVP, I know it is, but at the same time, people's salary are going up and, salaries are going up.
Oh, yeah, understandable.
It's hard to, be able to do that.
I would, if I could add one more thing, Alicia, I think the other thing you and I have talked about is that the HEI is great, but if there were somebody who could dedicate to coding, and this is probably what you were going to come in on, like if there were some work that could be done on what other indices could come out of the NDSR that would be packaged. Like, we've been talking about pregnancy-specific micronutrient indices. Like, could those already be established so that they're easily, or the inflammation, right? The inflammation markers.
The DII, yeah.
Yeah.
The DII.
That's
what I'm interested in, the DII as well.
Where the coding would come from that, because then we talked about that, whether or not Minnesota offered that or not. But we don't think so. I think the HEI is the only one that is provided, correct?
Yes.
Yeah. So that, yeah. Alicia, sorry, Melissa, I didn't mean that. Or is that good?
No, I mean, I agree with what everything Elaine just said. I've started working with Alicia as well, and she's fabulous. And actually, I didn't even know that the Bionutrition Corps existed. So that I was like so happy when Elaine told me that, because I was like trying to figure out who was going to do my 24-hour recalls. But in terms of the CTSC, like I will admit, like I'm still getting my bearings. Like I've only been here for 2 years, so that's something that I do want to become more familiar with. So it's hard for me to say like what else we need when I probably haven't utilized what already exists beyond Alicia's group. But I think for me, one of the hardest things here is just getting connected to clinicians, you know, like as a Case Western employee, like I don't have IRB. I mean, I don't have privileges at other universities in terms of the IRB. And so like, you can't really do much clinical research without those linkages to clinicians, because yeah, so as like a new person, I think that's one of the things that personally I could use the most help with. But I'm really excited about the training opportunities that Alicia mentioned. I even think just like as nutrition faculty, if there's like mini rotations that we could do. I mean, and we've started a new concentration for the nutrition PhD in applied nutrition, and like having opportunities for our doctoral students to get some rotations or training opportunities would be really awesome as well. But a great presentation. Thanks, Alicia. I learned so much more about the additional things that you all do that I didn't know before, which is awesome.
So Melissa, first thing I would ask you to do, if you can become a member of the CTSC, it is a 2-minute or less, you know, form. It allows you to get our newsletter, all the funding opportunities we have, all the services, and you can learn on the website quite a bit about what we do. And we're always looking to enhance our services. So that's why I said, if people need something that we don't know about, like, please let our navigator know. We have several people, we have a big hub now within the CTSC, which never happened before. The CTSC was just bits and pieces from different hospitals. Now we have our own mission-driven, 100% CTSC staff. And when I say staff, a lot of them have PhDs, but all they care about is CTSC. So we'll be more than happy actually to have somebody sit with you, you know, also try to explain what we do. So that's one. And then if you have a project and you need a connection, at least for UH, I know the clinicians there very well. I was there like for 8 years as the VP of research. So if you need any connection to an MD, at least I know the UH ones. I can help you with that. But yeah, let us know. I think communication with the CTSC is really like the first step. So we can see what research you do, how we can help you.
Thanks, I appreciate that.
So Alicia, I think you have a couple questions, starting with Aaron. Does Bionutrition use de novo? Oh, you're muted. You're unmuted.
Yeah, I was just curious if Bionutrition has used or currently uses NOVA classification. I know it's kind of controversial. It's not the best, but like using that in conjunction with like an HEI. I'm using NDSR data. I'm just, you know, to classify foods, you know, whether or not they're processed, ultra processed. I was just wondering if Bionutrition has used that before.
You're muted, Alicia. Yeah, we can't hear you.
Oh, sorry about that. I wanted to say that, no, we haven't. But this conversation has come up before about something being ultra processed. And so I went and checked just some questions I had for our association, that NARN association. And this is a common question. How do you classify it? NDSR does not classify it. There's just nothing, they haven't. So I feel like again, I have these thoughts that, oh, it'd be great if we could do this. This is definitely like a biostats. This is other cores that have to kind of assist with maybe coming up with a plan to figure that piece out. But also I wanted to comment on Tim, because I'm going to hold him to that. He says that he's, wants to talk more about collective and collaborative aggregate data on NDSR. So I feel like there's a way to do this. I need help.
Thanks for saying that, Alicia. This is my wake-up call to reach out to you and see what nuts and bolts we can figure out.
And they have, so DII is something that comes up over and over and over again. And there's a team that will calculate it from NDSR exports, but they charge you $13.50 a recall. So it's just another, if we could have it and have it be free, then let's do that. So I think
Well,
we just have
Tim
to
has, right? Tim's done it.
Yeah, so just very briefly, David Naginda Himana, who's actually UA staff and graduate of PQHS, did the original core DII coding, but it's derived from the initial version of DII, which was published. Some of the newer versions have proprietary adjustments, but you can make a DII that's not exactly the same as what they're publishing as of 2025, but it's still very close. And since what they're doing is proprietary, I actually prefer to build it myself or have David do it. David's pretty darn good at coding, but I'm talking too much. So.
No, like Tim, this is something as an example. I'm not committed to anything, but like something like this, if there is an effort for the CTSC to help with a project like this and say, we need that much resources, that's what we're here for. Anything that will enhance research areas like bionutrition. So please also, like I told Melissa, get to know the CTSC, and I would be happy to work with you and Alicia on something like that.
Thank you.
Any other question or comment?
Just keep funding them, Grace.
Yeah, I mean, I'm not a typical MD in the sense that I care a lot about bionutrition, as Alicia knows, and I've done, a lot of metabolic studies of HIV and now long COVID. So to me, that's one area that I'm excited about the new government, focus on it, because I do think what we eat is really bad. And just wait until somebody needs GLP-1 is not the solution. So I agree with RFK on that for sure.
Hey, Alicia, I have a question.
Yes.
Our pilot navigator and me and we're all at the CTSC, and our grant proposal people, we see grants all the time. We see people are requesting our funding. And I'm wondering if you could maybe talk with us about, even on a, offline, about what studies would be good to have nutrition as a secondary aim. Like what should we be looking for?
Let's talk.
That's a
great idea, Jerry. That's true. Any other good idea? So Alicia, actually, Aaron and a group of us who work on HIV, we're gonna look at ultra processed food. That's like a biggie, and I do think it contributes to the inflammation in our patients. So we may get your input on it as well.
And I also wanted to add, because it's been on my mind, is I know we're heavily invested in the nutritional aspects of all of this, but also physical activity. And I know that there's I don't think there's enough investment and also consideration for physical activity. And I think there's there's definitely enough opportunity here to evaluate what could we do at scale to enhance physical activity from a prevention standpoint, because I know RFK is right on with that as well. Reducing chronic illness with physical activity, and you walk in into any waiting room, it's just people sitting around. It's like, do they need to be sitting? And I think like doing a research study that evaluates preventative physical activity would be, I don't know, I don't think it would be that costly, but just a consideration.
Yeah, and Aaron, I can tell you from someone who got bad comments twice on a study in HIV, looking at physical activity and exercise, just reviewers are the problem. I mean, people say, oh, why you're not doing more studies? Well, first you need to get funded. So yeah. The reviewers are a big problem. They always want, biologic. You can give them like any biologic agent with tons of risks. They see that as way more appealing than doing a physical activity or in the bionutrition research. So that has been the issue, Aaron. I mean, I know from HIV, like I learned the tough way, and the comments are stupid. Like, why you're doing that? Of course, physical activity is important. Yeah, there's a problem. And I think this is why you see restructuring of study section, because if they are really smart and they want to put more money into doing good research on nutrition, on physical activity, it starts with reviewers who are deciding on these applications. You need people who value this type of research. So hopefully we'll see that.
Sure. Yeah, that makes sense. I think hamsters, they fare much better when they have a wheel available versus hamsters that don't. So
Exactly true. All right, 2 minutes. Any other comment or? All right, well, Alicia, I'll tell you, thank you for everything you do. And this is why we have bionutrition within the CTSC, and we are committed to enhancing it more and more. So anything we can do, like Tim, Melissa, I know others, even though they didn't speak up, let us know. We're always entertaining more stuff to fund in the CTSC. All right, thank you.
Thank you, cheerleader.